saying for past several years. So the risk of infection is about 1 to 2% in primary joint replacements, and in revisions, I think it's going to go on, as you see from this Kurz's paper, 60% revisions probably for infection by 2030 in the United States. There are a couple of definitions we need to talk about. One is the Musculoskeletal Infection Society, Intercollegiate, what is it called, ICM, which was in 2018, and they revised their own criteria from before, and they have two major criteria, which if present, infection is present, and then there are minor criteria for preoperative diagnosis, and there is a scoring system. And if you add the score, more than 6 is infected, 2 to 5 is possibly infected, and 0 to 1 is not infected. And for intraoperative diagnostic, again, you consider positive histology, purulence, and a positive culture. And that way you can make a diagnosis for PJI. However, at the same time, the European Bone and Joint Infection Society, EBJIS, came up with their own classification for PJI, where they divided into 3 groups: infection unlikely, infection likely, or infection confirmed. And how do they decide that? They give a lot of importance to clinical features, as we can see here. C-reactive protein, again, is used as a suggestive criteria, not as a confirmatory criteria. The synovial fluid cytological analysis has got definite importance. There are several papers which range the cutoff point from 1500 to about more than 3000. And I think if you got more than 3000 in the synovial fluid, it is confirmed. Less than 1500, it is unlikely. So I think in that way, the synovial fluid biomarkers and the aspiration, we will go one by one about what is the cutoffs for each of these. So there are several definitions. As I said, the MSIS first came in 2011, and then they changed on in 2018, and the EBJIS criteria, which are very good actually. I haven't been following them so well, and they have again classified these infections or diagnosis of infection. So the classification for infection, again, is a different classification that is based on the clinical presentation, severity of symptoms, and temporal relationship between the index and the onset of infection. We all are aware of this classification. Type 1 is early post-op, type 2 is a late chronic infection, 3 is a hematogenous infection in a well-functioning prosthesis, and type 4 is where you send cultures and they've come positive. Diagnosis of a PJI rests on 4 pillars. These have not changed. You need to get proper clinical history, risk factors, clinical history, radiology, and the lab test. Clinical, we all know: pain at rest, night pain, persistent wound discharge. X-rays, unfortunately, will not tell you much in the early days of the diagnosis. For late infections, we all know the signs of radiolucences and periosteal new bone formation. Technetium bone scan as well as the Indian labeled bone scans are only done to rule out if all other tests come back as equivocal and the tap or the aspirate from the joint is negative. Let's see at the ESR, CRP, and the WBC counts. These are the serological tests. ESR is sensitive but not very specific. However, the negative predictive value is pretty decent. Unfortunately, it remains elevated for nearly 6 months following surgery. CRP, more than 10 is considered a cutoff. Again, negative predictive value is very high, but sometimes in inflammatory pathologies, you cannot really rule out. And unfortunately, in the immediate post-operative period, CRP will be raised, and it remains raised for nearly 3 to 4 weeks. The WBC count on the hemogram, unfortunately, is affected by several factors: the immune response, the host response, presence of antibiotics. So I think it is not very useful. Now, D-dimer is something new which has been added in the MSIS definition, which is basically a fibrin degradation product, but this is also produced by inflamed synovium, and the subsequent breakdown of this fibrin will lead to elevated D-dimer levels. So I think this is being used more frequently for intervening after the first stage in arthroplasty. However, joint aspiration remains the most important step. The sensitivity and specificity, as you can see, is high, but the negative predictive value remains very high as well. You need to look at How do you collect the swab? You need to stop antibiotics, sorry, not the swab, but the aspirate. You need to stop antibiotics. You need to use proper precautions while collecting the samples, and the transport is extremely important as well. So if you aspirate the joint and leave the sample out in the open for a long time, or you give it to the lab and they don't process this, it's a problem. So you need to use blood culture bottles if possible, so that there is the transportation becomes easy. There is less exposure of aerobic environment, but unfortunately the cost increases. You can see the organisms. There are Staph aureus, epidermidis, streptococci, but gram-negative and anaerobes are present as well. So each time we send cultures in our lab, we send for aerobic, anaerobic cultures, acid-fast, bacilli, atypical mycobacteria, as well as mycobacteria and fungal cultures. Length of incubation is important as well. So you get all the culture media to be sent. Transportation is important, and minimum 5 days is essential, but 26.4% more infections were detected if the cultures were held for 14 days. So in our labs, we tell them to keep the cultures for at least 2 weeks in the microbiology. So you need to follow all of these. Swabs are not good because of the reasons given here. Some of the organisms cannot really survive on a swab, and some adhere to the swab, so they can't be transferred to the media. So you need to remember that as well. So in test, what are the tests that we do now? Obviously cell count is the cheapest, can be done manually, and it's most predictive along with ESR and CRP. As I've told, the EBJIS criteria, less than 1500, you rule out infections in the synovial fluid, and more than 3000 with 80% polymorph can be confirmatory for diagnosis of infection. The MSIS criteria are similar as well, more than 3000 per high power field, with neutrophil percentage of more than 80% is confirmatory of the diagnosis. However, you will get false positives in post-operative patients where there is blood, hemarthrosis, failing metal on metal, and inflammatory arthrosis. What are the molecular markers? NGS, the next generation sequencing, is one of the new method. In our hospital, we have got the 16S amplicon targeted. I'm not too clever, I just checked with the microbiologists yesterday. And then there is new thing called as shotgun metagenomics, which unfortunately is not available with us as well. PCR, unfortunately, can lead to amplification of contaminating genetic material, so we don't use PCR, we stick to NGS. What about synovial fluid biomarkers? Leukocyte esterase, alpha defensin, CRP, and synovial calprotectin. Leukocyte esterase, you can do a simple urine dipstick test. You can use the same thing. You can use a drop of synovial fluid. Result is possible in 1 minute. It is easy, low cost, real-time results. However, if there is a bloody tap, then it will not be good. You can do a centrifuge and take the plasma from it for a leukocyte esterase. And it's a point of care test. So you can do it bedside, which can make you take decisions as well. And this is the papers from leukocyte esterase with sensitivity and specificity given here. Alpha defensin is again a protein. You can do a lateral flow test for it, which was marketed by Zimmer as Synovasure, which is pulled out from Indian market, but the sensitivity and specificity were good as well. And something new which is now available as a lateral flow test is a synovial calprotectin. Unfortunately, that is not available in India as yet. It's not very expensive, can be another way of diagnosing point of care treatment. Culture intraoperatively remains the gold standard. If you are not able to make a decision during the second stage, then I think you can rely on a frozen section. There are criteria you need to discuss with your pathologist so that they can make the right diagnosis. More than 5 polymorphs per high power field in more than 5 samples is confirmatory of infection. So these are the sensitivities and specificities for CRP, synovial cultures, leukocyte esterase, and you need to look at test with the most smileys that are present on your chart. So serum biomarkers and synovial biomarkers, as you can see, are the two modalities of diagnosing infection on a joint aspirate. So joint aspirate does remain the foundation. There is rising incidence of PJI. You need to make sure how you diagnose them well. There are a couple of definitions. MSIS was the most popular, but EBJIS I think is looking more and more sensible. The 4 pillars of diagnosis have been discussed, and then there are newer diagnostic tools such as the lateral flow test, and you can also do a ELISA test for synovial fluid for alpha defensin. That is also very specific, but unfortunately that is not available in many of the labs. Thank you.